All right, people, welcome back. It is June 6th, and we are continuing with our neuro chapter. Last week, I think we had left off on slide 29, and we were talking about some of the basics of neuro again. Neurons are functional units of the nervous system, basic functions of the nervous system as a whole, and where we ended up, the PowerPoint was just shifting over into a CNS type of category. So obviously we're going to talk about the brain, different parts of the brain, what they do, cord. So we'll look at a cord cross section and tracts kind of together. It's just, again, repetition. A few new things we'll probably cover today. But overall should be a little bit of a review, and then we'll kind of spread and mix in the pathophysiology with the different parts of the brain again. And I guess in a simple fashion, what we do, and I'm sure I've mentioned this before 800 times, when we're studying neuro, the application of that is basically just localizing lesions again. So let me go ahead and kind of share the PowerPoint with you real quick. I've already opened mine up, but again, this is what we were doing last week. It's the same PowerPoint. It's just, we're going to pick up on slide 30 here. It's basically when you go over the brain or the cord, we talk about the different parts and pieces. So I thought that was kind of funny right there. But this little cap that somebody knit themselves, what they did is they knit the little gyri and the sulci in the brain. And that's kind of actually neat to see it in 3D like that. I think that would be a good Christmas present for people this year. So if you're looking for ideas, I'm sure you can buy this thing on Etsy. But the nice thing about it is it shows in kind of 3D that these parts of the brain are physically separated from each other. And there's different blood supply to these different parts of the brain. And if you end up throwing a clot, or if you have an aneurysm that ruptures, this part of the brain might be affected, but this part of the brain might be spared. So that tells us something. So as we systematically go through the different parts of the brain and go through the different parts of the cord, and we talk about this part's responsible for this, and this part's responsible for that, when we start to see deficits in what those parts are supposed to be doing, we are better able to then what's called localize a lesion. So one of the first localized lesions that ended up being noticed in people a long time ago was due to a patient becoming aphasic, or they had what was called Broca's aphasia. So we'll talk about Broca's area. It's a little small space in the frontal lobe, and its main job is for again, vocalization. It's basically trying to give you the ability to speak and talk and kind of put everything together, what it takes to, breathe correctly, pass the vocal cords, to use the tongue and the mouth to articulate the words. And if that part of the brain that's responsible for that is affected by, say, a stroke or some type of injury, then we'll lose the ability to vocalize. And so the person might become mute. So maybe yesterday they could speak, today they can't. What's happening? Well, what part of the brain is responsible for speaking? Broca's area. So maybe something is wrong there. That's a perfect example of localizing a lesion. So that's kind of how we're going to take it today, similar to the way we always do it. But again, neuro does end up taking up quite a large percentage of the amount of material that we cover. And I think it's just because there's so much to cover. So before we get into it, we can look at this slide. I think this is pretty much just as good as all the other slides that we look at. It's pretty accurate, I'd say. It's got the male brain separated from the female brain, what most of the brain is kind of taken up by. It's kind of similar to like the homunculus, you know what I mean? Like the homunculus, it shows how much portions of the brain are dedicated to like motor control of the hands, or sensory coming from the hands, or maybe sensory coming from the lips or the tongue, and the parts of the body that are most sensitive actually get the most real estate in the brain. So this is very similar to the homunculus, where it shows, things that boys tend to think about, things that girls tend to think about, things that men are good at doing and things that women are good at doing. I thought it was pretty accurate like that. So go back and look at this sometime. And when we get into the brain and the cord, there's also surrounding structures. So, of course, the skull, the meninges, the cerebrospinal fluid, this is meant to protect the cord and the brain. And so if any of those areas get messed up, or maybe there's inflammation, or maybe there's some type of pressure in between the skull and the brain, that could end up causing problems. So real briefly, we'll get into that real quick too. And one of the first things we usually talk about when we talk about surrounding structures around the brain is the meninges itself, which were the membranes, right? So some of the functional parts of the meninges, of course, you have the different layers. You have the dura mater, you have the arachnoid mater, and you have the pia mater. And it's always good to memorize things from, say, superficial to deep, or external to internal, unless you're doing the GI tract, and then we usually do it opposite. But from superficial to deep, the first layer that we would end up seeing in the meninges is the really tough outer layer called dura mater. And the basic functionality of what this does is it does surround and protect the brain, and it kind of keeps it centered within the skull. So you'll actually find portions of the dura mater attached to the skull, like you'll have a periosteal layer to the dura mater, and then you'll have a more internal layer of the dura mater that's facing toward the brain. It's not in direct contact, of course, pia mater is, but it'll actually kind of form these little partitions or these little walls in between, say, the two cerebral hemispheres, and between, say, the brain cerebral hemispheres and the cerebellum. So I know that's kind of hard to envision, but like if we look at this picture here, you can end up seeing that the main portions of the brain, the cerebrum or the two cerebral hemispheres, there's this large kind of space in between, and that dura mater will actually attach to the skull out here, and it forms little partitions or walls in between the two cerebral hemispheres. And you end up getting another partition that ends up forming between the cerebral hemispheres and the cerebellum. So if you ended up doing like a brain dissection in labs, those were some of the structures that we actually had to physically cut through with the scissors, remove it to be able to see the brain, because it was real tough stuff. And some of it was sharp on the outside because you actually had pieces of the skull coming off with it. But we had to cut those things loose so we could get in here and see the brain a little bit better. But that's one of its basic roles, is to hold the brain in place. So for example, if I have like let's say we're looking at the brain forward facing this way, and let's say that's a cerebral hemisphere right there, and that's another cerebral hemisphere right there. So maybe this is the right cerebral hemisphere, this is the left cerebral hemisphere. Your dura mater would be attached to the skull itself, but it also forms these blade-like partitions, and they kind of form like what's called a sickle shape. So they end up calling it a falx cerebri. And what that does is that keeps the brain from shifting too far one way or too far the other way in the skull. So if you end up getting what's called coup or contra coup injuries, like for example, if this is the head, big lips. He's a kisser. Let's say the brain is in motion and it hits a stationary object, or let's say that the head itself is stationary and some type of moving object hits the head. So let's say we got like a fist right here, right? And that fist is moving and it hits a stationary head. The brain itself can rattle inside of the skull. So we end up calling those things coup and contra coup injuries. One of the roles of the meninges is to keep that brain from shifting around too far, because again, you're going to have some cerebrospinal fluid in here, right? And then you're going to have that very tough, dense skull, which is the main form of protection. But because the brain's real sensitized, you don't want it bouncing around in here like a BB in a boxcar, right? That's what my dad used to call my brain in my skull. But the dura mater can help keep it in place. So again, this way we're not shifting too far right, left. And we also have some partition between, say, the cerebral hemisphere and the cerebellum right here that keeps it shifting too far front to back. But if we do take too much of an injury, like if the force is too great and the brain does shift inside, this can actually tear, which leads us to one of our first types of conditions. So again, basics is your brain is very sensitive to localized changes. And one thing that the brain doesn't like is pressure. So that's an idea that we've covered so far. So in order to minimize change, your brain is surrounded by a very dense outer skull, right? Very tough bones, believe it or not. And the brain, of course, sits inside of that. But instead of just sitting a soft, delicate brain inside of a hard, bony skull, we're going to add a couple of more extra layers. One extra layer that we're going to add is some meninges here. And the meninges, of course, will protrude toward the brain in certain areas to kind of help keep it in place. And then we're going to add some fluid in here, specifically in what's called the subarachnoid space. So between so you got dura mater, arachnoid mater, and pia mater. This is all review stuff, so that's why I'm not really going into it too much. Not only do you have the 3 layers themselves, but you also have spaces between the layers and even beyond, right? So this would be like an epidural space. This is a subdural space. This is subarachnoid space. So here we would have CSF, or cerebrospinal fluid, right? And so that adds another layer of cushion. But if there's too much movement or too much trauma inside of the skull, we could actually cause tears, right? And one thing that could end up happening is you could tear that dura mater right here. And when that dura mater gets torn, right, you could end up getting what's called a subdural hematoma, right? So if a patient presented with a subdural hematoma, chances are they're going to be presenting with some type of headache and some type of neurological changes, right? So things we might look for, maybe they pass out. Maybe they have what's called projectile vomiting, right? Nausea is a neurological indicator. So again, some of these things might look similar to migraines in a certain way, shape, form, or fashion. Some people get migraines and they'll have nausea. Sometimes people get migraines, and of course, obviously there's headache that kind of comes and goes, but it's not quite so pulsatile in nature. It's pretty consistent. So if somebody has a subdural hematoma, the most likely question you're going to ask that patient, if you think that's what they're presenting with, which would be maybe worst headache of my life. Usually it's going to be pretty heightened at the onset. Like once a person has a subdural hematoma, it usually starts bad and stays bad, which that'll kind of help differentiate it from maybe subarachnoid hemorrhage later. But again, there's going to be some type of neurological symptoms along with that. So maybe their cardinal fields of gaze is going to be messed up too. Maybe they'll have nystagmus, right? So again, there's a lot of different indicators that could indicate that there's neurological involvement, but worst headache of my life, some type of signs of neurological involvement. And it could just be because that they have some type of pressure on the brain. But in this case, the pressure came from trauma. The brain shifted around in the skull. It caused the dura mater to be torn, and that dura mater itself will bleed. And when you end up getting that blood in between the layers in the brain, that creates the pressure that's going to cause the neurological symptoms. And depending on which part of the brain it is and how severe it is, I mean, you might end up having to remove parts of the skull just to relieve the pressure. But again, how would you differentiate, say, a subdural hematoma from any other type of headaches or any other type of trauma? Again, worst headache of my life, usually starts off pretty bad and you have a lot of neurological symptoms, maybe confusion, right? But again, eye changes, maybe you're even going to get balance changes depending on where the pressure is coming up. But nystagmus, nausea, projectile vomiting, those are good indicators. Maybe you would even have signs of upper motor neuron lesions. So maybe pathological reflexes would come out. Maybe they would be hyperreflexic. Maybe they would have increased muscle tone. Maybe they would have posturing, something like that. There's always something that's going to indicate that there's something wrong with the brain. And if you need a visual reference, you can look up things like cortical fisting. You could look up decerebration. There's certain things you could probably YouTube if you wanted to, but you know what I could maybe show you now, just using the little camera that we have, is sometimes a patient's hands might curl up like this. And so if somebody's presenting with a really bad headache and they seem to have their hands real tightly curled like that, that's a bad sign. That is not good. So sometimes you might end up seeing football players do like this. when they get real bad concussions. Like you'll see that their hands start moving involuntarily and they start to twist, or maybe they even extend out like this, right? So depending whether the cerebrum's affected or the cerebellum's affected will actually give you different movements. But again, you have an increased tone and it's involuntary. So that's another really good indicator that there's something going on with some of these surrounding tissues and there's pressure somewhere up here that there's not supposed to be, right? So the brain doesn't like pressure. So one way we could increase pressure to the brain is we could have a tear of the meninges, something like a subdural hematoma, right? So that's an actual physical tear of the dura mater. Another one that you'll hear about sometime could be what's called a subarachnoid hemorrhage, right? And these words are right down here at the bottom if you're looking for them. So subdural hematoma, subarachnoid hemorrhage, and a subarachnoid hemorrhage usually comes from an aneurysm. And sometimes this is a word that if you're not super familiar with what it is, most people know the results of an aneurysm, which is a rupture or a dissection or a hemorrhage. But the aneurysm itself isn't physically a tear. An aneurysm just means a ballooning of a vessel. So believe it or not, that by itself could be enough pressure to cause changes or problems in the brain. Turn on another light here so it stops flickering. But that itself is the aneurysm. And sometimes one of the things that might increase our likelihood of having aneurysms could be vascular changes, maybe too much smoking, too much drinking, a lot of drug use could increase the likelihood of having aneurysms. And then very unstable blood pressure. Like if somebody has a pulse pressure that's too high, that increases likelihoods of aneurysms. And I know we're kind of jumping around subjects here, but pulse pressure was the difference between your systolic and your diastolic pressure, right? So normal numbers like 120 to 129 over, say, 80 to 89, notice the difference between the two. Like if you're somewhere like 30 to 40 points off, that's usually pretty good, pretty normal. So if you're like 120 over 80 or 110 over 70, that's great, right? But let's say that one of these numbers is kind of normal. So let's say my bottom number is normal, but the top number is 160, right? So is that bad? Yeah, that's bad. And it's not that both numbers are bad. That number actually looks really great. But that number is not only high, but the space has increased too much. So now you have greater than 40 millimeters of mercury pressure in there. And the higher you go, the more likelihood of aneurysms and ruptured aneurysms you're going to get, because the blood becomes too pulsatile, too much distension, too much recoil. And so it can cause little micro tears inside the vessels. And if you're already a smoker and a drinker, that's going to make the micro tears more likely, because it'll change the inner lining inside of the vessel, and you can actually get cracks, like almost as if you had too tight or too dry a skin. It'll crack sometimes. If the inside of the vessels are too calcified, as you pulse blood through it and they extend and compress and extend and compress, or distend is probably the better word I should use, it can cause cracks in between it, and blood will get in between the cracks. Right. And as that blood starts to flow in between the cracks, it starts to balloon it out more and more and more. So this itself could be a problem. But obviously, the bigger problem would come as if this ruptures. Right. So as it gets more and more distended, it's going to get thinner and thinner. So eventually blood could escape. And now you have a dissected aneurysm. Right. And so when the blood leaves, of course, that's going to create its own swelling or mass or clot, So anywho, that is more descriptive of a subarachnoid hemorrhage, right? So presentation-wise, you're probably not going to get much difference between a subdural hematoma and a subarachnoid hemorrhage. One of the big differences, though, is this one's actively bleeding, and this one's probably already done. So a lot of times what the subdural hematoma ends up being is clotted blood that's kind of sitting on the brain that can't go anywhere. So again, you might end up having to open up the brain to relieve pressure. You might have to open up the skull, not the brain itself. But with a subarachnoid hemorrhage, this is an active bleed. So maybe you sneezed and all of a sudden you have a headache and stuff like that. But the difference is it gets progressively worse and worse and worse because it's an active bleed. So again, maybe worst headache of my life, you're going to have neurological symptoms and it's getting progressively worse. That's sometimes what we would use to separate a subarachnoid hemorrhage from a subdural hematoma. This one would obviously have trauma preceding it. This one could come out of nowhere. You don't even have to sneeze. It might just rupture, right? So obviously, we can't always ask the patient if they're unconscious, but again, if they are, they can't tell me that they have a headache. They can't tell me that they have double vision and stuff like that, but I could still maybe look for posturing, right? Maybe the hands are all tight. You know, maybe you could do some type of like a Babinski response. So if you know they were in, say, like a motorcycle accident, and you know that they did hit their head, but they were wearing a helmet, you might not see damage on the outside, but you could still assess for damage on the inside by doing some of those pathological reflexes. So Babinski might have been one that we had mentioned before in one of our classes, right? And similarly, meningitis, of course, if you have any type of infection or inflammation of the meninges themselves, which most of the time would usually come from some type of bacterial infection, viral infection, or fungal infection. That could actually cause the meninges themselves to swell. And any type of, again, pressure on the brain is going to equal problems. So with meningitis, usually there's some form of, again, infection present. So when a patient has infection, there's two things we look for. You look for pyrexia, which is fever, and you look for leukocytosis. So these would be present with meningitis usually. So leukocytosis is increased white blood cell count. So we'll talk about this again when we get into more of an immune type section, when we do lab diagnostics and stuff like that. But again, this is a little bit repetitive of things that we probably saw in lymphatics and immunity. So infection, again, there's two things. Like you can have leukocytosis without pyrexia. It's probably not an infection. You know, it could actually be something worse, right? Could be leukemia or something like that. But if you have both present, then let's go ahead and assume that there's some type of infection. So what are likely candidates for infections? Usually the pathogens, right? And pathogens are usually known causes of diseases. So bacteria, right? Virus, and you could even get parasites and stuff like that. But if we're talking about meningitis, usually fungus is another cause, like black mold or something like that. But let's say you have a bacterial infection, a viral infection, a fungal infection. What is the patient going to present with? Probably sickness, you know, again, fever, maybe sweating, maybe chills if it's a viral infection. They're just going to present as a normal sick person. But again, there's going to be neurological involvement. So that's what's going to separate a normal infection from an infection that's also caused meningitis. So there's certain things that we can use to confirm this. So maybe, again, they're very sick and they have a really bad headache. Or they're really sick, they have a headache, and they're starting to show some type of neurological changes. So one thing that we might end up doing with a patient is we might flex, you know, the head forward and see if there's any kind of changes. You might just ask the patient if they have what's called nuchal rigidity, like a really rigid neck. That's a clear sign that meningitis might be present. So we call it nuchal rigidity. It's kind of like the back of the neck is frozen. They can't bend the head forward. They can't turn the head, rotate it one way or the other. And if we go and we break through that rigidity and we flex it on them anyway, what you'll notice is their body will flail, right? So maybe if they're laying on the bed and your hand's on the back of their head and you flex it forward like this, like you flex the chin to the chest, you might notice that their legs pull back, right? Their legs jump. So we sometimes call that frog legging, when the legs kind of bend at the knee and flex real quickly. So that could be a good indicator that meningitis is present, right? So, but anywho, not a difficult diagnosis there. A lot of times, you know, what's going to give it away to it is they're going to describe the nuchal rigidity. They're going to be like, yeah, I feel sick and I cannot move my neck, right? And you're like, ooh, that's not good. Right? So typically, usually worst kind of meningitis, somebody can have, and I mean this from like a normal perspective. Like if you took, 100 people of all different ages, usually the worst type of meningitis is bacteria. And it's not because this is more lethal than, say, viral. I mean, you could die from either one, depending on your age and any type of background that you have that might make you more susceptible. But this is a lot easier to spread, right? So if somebody has bacterial meningitis, you have to, alert that to CDC. And so there's probably going to have to be a quarantine and all that type of stuff. So to determine which type of meningitis that we have at that point, you're probably going to have to do some type of CSF test, right? See what's going on with the CSF. And if it's bacterial meningitis, you'll have increased protein in the CSF, but you'll have decreased glucose. And the reason that the sugar goes down with the bacterial meningitis is the bacteria feeding off of it. So that might be something that would be indicative of not only that, yes, we have a problem going on, the increased protein indicates that, because maybe if I have more inflammation, protein can leak out of vessels. And if I have more, say, antibodies are a type of globular protein sometimes, right? And so antibodies can increase the protein concentration. So that's not really indicating any one thing in particular, other than there's inflammation or infection. But the decrease in glucose could tell me better why or what type of infection. So anywho, let's get off this. As we get into the cerebral hemispheres, a lot of times what we like to do with these things is we like to subdivide them up. So there's terms right here that I'll be using. Pictures make it easier. But one thing we'll do is separate it into lobes, of course. When you think about the cerebral hemispheres, these are the main parts of the brain, like the word cerebrum kind of means brain. Where cerebellum, which is a very similar word, kind of means like little brain, right? Big brain, little brain. So when we think about the brain, we mostly think about the cerebral hemispheres. And so we subdivide these things into lobes, and then within the lobes themselves, we can subdivide them into the various, gyri, sulci. So the gyri are the lumps, and they sometimes will be numbered or named or both, right? Like we might call this the precentral gyrus. We might call this the postcentral gyrus, even though this kind of looks funky. I'm not sure what's going on with this brain, but still, it's behind the central sulcus. So this would have to be some type of postcentral gyrus. This little area right here, we could call maybe that a motor association area. Maybe we could number these areas 4 and 6 right here. So obviously there's something important about it. So not only are we going to subdivide the brain into different parts and pieces, like you have a cerebrum or cerebral hemispheres, you have cerebellums, you have brain stems, but even within those areas, we're going to subdivide those up. So with the cerebral hemispheres, we subdivide it into lobes first, and then you can even subdivide it into the various gyri and sulci. So again, the little lumps and bumps and grooves. Two that I usually hit on a lot when we first start studying these things, precentral gyrus and postcentral gyrus. So I went ahead and kind of labeled these for you. And when you get into the precentral gyrus and the postcentral gyrus, a lot of times you're talking about some of the very basic functions of, say, the frontal lobe of the cerebrum and the parietal lobe of the cerebrum. So when I think about parietal lobe, most of what I think about is somatic sensory areas. Like you have a portion of the brain that's really good at picking up like touch, pressure, proprioception, burn, itch, things coming from skin and joints, So it's the stuff that we're usually pretty consciously aware of, and it's the stuff that I can feel, right? So again, that's why we say stuff like skin and joints, because those are the things that I can sense consciously. Not the same as like pH of blood. I don't consciously sense that. That's sensory information that my brain needs, but not necessarily in the parietal lobe, and it's not something I'm aware of. So again, you get in terms like somatic afferent versus visceral afferent. So when I think of parietal lobe, I think mostly somatic sensory, stuff that I can consciously feel. Occipital lobe, think about vision, interpretation, temporal lobe, auditory sense. balance. When I think about the frontal lobe, quite a few things, but voluntary motor function for sure, because this whole area here and this little area here is all about voluntary or skeletal muscle control, right? This little area up here, cognition, higher thinking. This little area right here, Broca's area is basically motor for speech. So some of these things, of course, a little bit more labeled here. Like here, it's got Broca's area kind of pointing right here. Usually most pictures will put it a little bit further back, but that works. Who cares? All right. So if you got pressure on the brain right there and they can't talk, absolutely. There you go. That's Broca's area for sure. But precentral gyrus, also known as the primary motor cortex, and postcentral gyrus, also known as the primary somatosensory cortex. We oftentimes use these as demonstrative ways, a way to demonstrate how neuro gets taught and then how we use that. So for example, again, when I think about the precentral gyrus, the lump of the brain in front of the central sulcus, so this is kind of like where the frontal lobe starts, its primary job is to control skeletal muscles. That's all it does all day long, right? And it's mapped out in a way, like if we use what's called our motor homunculus, where we have certain areas of the brain dedicated to just controlling the hands. We've got certain parts of the brain dedicated to just controlling the feet. Certain parts of the brain are dedicated to controlling like the eyes and the mouth, swallowing muscles, perhaps. The tongue, look at that. It's huge, right? But tongue actually gets used for a lot of very important things, like chewing. Your tongue's very active when you're chewing. It's feeling the food, which is sensory, but it's also moving the food under the proper tooth. And when we talk, the tongue has to move in a very particular way. So it makes sense that it has a lot of area of the brain dedicated to just moving that tongue. But what if this part of the brain was damaged, right? Or what if hypoglossal nerve got damaged? Either way, I'm going to lose control of the tongue, right? Or what if this part of the brain got damaged? Maybe I won't be able to move the hand anymore. And so that's the idea. If we know what different parts of the brain do, and we know what they're responsible for, if I have pressure right here or a lesion right here or some type of damage right here, then we're going to lose that ability. So that's why we describe certain areas more than we describe others, because we're really sure what this area does, and we're really sure what this area does. So if you go and you mess up that area, I'm not going to be able to feel things anymore. If you mess up this area, I'm not going to be able to move things anymore. And a lot of times strokes will affect this area, right? So when you see somebody with some type of circumduction gait or hemiparetic gait, usually the stroke has occurred and it has affected this area, right? So we could probably Google that if we wanted to. So like a circumduction gait. If we look at that, for example, this is kind of showing what's happening. Let's see if we can do a GIF so I don't have to go to YouTube or anything. So here, this is the affected leg. This leg's working kind of normally. I know it doesn't look normal, but it's trying to basically compensate. This is an entire hemiparetic gait right here where you can actually see the elbow has been bent. It should be tucked a little bit closer into the side right there. The fingers should actually drop a little bit looser right there. This is just somebody, I think, demonstrating. But that's a hemiparetic gait, like where the entire, let's say, left side. So this is right side of the body, right? So the entire left side of the brain has been affected at that precentral gyrus. So the leg is stuck out in an extension. So in order to get the leg moving forward, she's having to circumduct it around because she can't dorsiflex the foot. She can't flex the knee. All the extensors are stuck in position because it's hypertonic, right? When you have brain or cord damage, any type of movements become stuck or spastic, right? So you end up getting this type of paralysis where there's too much and we're not able to dampen it. So things get stuck, right? So you look for hyperreflexia, hypertonicity. This is a spastic tone. So her leg's stuck in extension while the upper extremity is stuck in flexion, right? So this person has had a stroke on the left side of the brain where that precentral gyrus is. So you're getting the cortical fisting, you're getting the upper extremity stuck in flexion while the lower extremity is stuck in extension. That's the gait they would have. It's a pretty telltale sign. It's easy to identify, right? And this is a form of paralysis, right? So usually when I first start teaching that to people, they're like, that doesn't look very paralyzed, right? Because they're not in a wheelchair, but can she move the arm the way she wants to? Can she move the leg the way she wants to? No, therefore it is paralyzed. This just happens to be a type of spastic paralysis, which is a good indicator that it's an upper motor issue. So brain or cord damage has occurred, right? And that's just little tips and tricks that you can always use to tell if there's any type of brain or cord involvement. When things start to become spastic, when you start to get posturing, you know there's pressure or a growth or a tumor or a bleed actively somewhere on that brain or cord when you start to see stuff that's stuck like this, right? But it's not always going to be indicative because we're not always going to have motor involvement. But if the problem occurred here, you'll absolutely have motor involvement, right? And sometimes, you know, things will show up temporarily and then they'll disappear. So maybe that's what could help us differentiate, say, a stroke from a transient ischemic attack, right? You ever heard of that before? So obviously, when people have strokes, strokes can occur pretty much anywhere in the brain or the cord, right? And if you know what different parts of the brain do, and if you know what different parts of the cord do, then we could localize that stroke, right? Just by looking for deficits. Like if I can't see anymore, maybe let's look in the occipital lobe. You see where I'm going with this? If I can't move appropriately anymore, let's look at the frontal lobe, because the frontal lobe's very, you know, important for movement. It's not the only place in the body that can control movement. Obviously, peripheral nerves have to get the information there. The cord has to send the information out unless it's coming from a cranial nerve. But again, it gives you an idea of how we can start localizing stuff better. And if it's a brain, again, and movements affect it, then we're going to have signs and symptoms of upper motor neuron lesions. And if it's a peripheral nerve, then we would have signs of lower motor neuron lesions. So again, increased reflexes, increased tone, right? This is decreased reflexes. This is decreased tone, right? This would also have more pathological reflexes present. So again, pathological reflexes could be presence of a Babinski response, which if they're 9 months old, it's okay to have, but if they're 19 years old, they should not have that anymore, right? So Babinski response is only normal up until about 9 to 12 months of age. Then it disappears because your brain's like, hey, it's not awesome to have the bottom of my foot rubbed. So I shouldn't be presenting more, I should be presenting less. But if your brain is inhibited from being able to get that signal out, and you go and you scrape the bottom of somebody's foot and their toes flail like that, that's a pathological reflex. It's just saying something is inhibiting my normal cortical dampening or my normal cortical intervention, right? Because it took you 9 months as a baby to figure that out. We're very stupid when we're little, right? We're so stupid, you scrape the bottom of a foot and it's like, yeah, right? But then the brain's like, no, idiot, right? So it learns. But if there's something inhibiting the brain from getting that signal to the bottom of the foot, you go and you scrape it again, and then it comes back, that's a problem. It's indicating that there's a problem, right? But there's lots of different pathological reflexes. If you want to see if somebody's got brain involvement, just hit the fingernail real hard. Just tap the fingernail real hard and see if that hand overcompensates for it. Like if you tap that finger, you know, every once in a while, you'll see another finger move or something like that. You might see this little finger moving a little bit. It's okay. But if I start to see this, that doesn't look right, does it? There's something pressurizing the brain. So you can do that even on the unconscious patient if you want to. You tap that finger real hard and their whole hand flails like this. There's pressure on the brain or the cord, right? So it's telling you where the problem's at. It's telling you. So again, these are all just tools. They're tools. But anywho, I know I was saying something totally different before I was getting into upper and lower motor neuron lesions, but the moment is lost and I forgot what it was. So I'll come back to it when I remember it. Things to be aware of for tests and standardized testing. Why do we call this the precentral gyrus? Why do we call this the postcentral gyrus? Simply enough, it's a lump, so it's called a gyrus, and it happens to sit in front of the central depression, if you will, sulcus. So a sulcus is a depression, a lump is a gyrus, right? This happens to be a very important depression, and it's a really deep one too. It's actually what creates the separation between your frontal lobe and your parietal lobe, right? Like between your temporal lobe, frontal lobe, and parietal lobe, we can see that very deep depression. So sometimes that might be called a fissure, right? It doesn't have to be, there's no hard rule. That might be sometimes called a fissure, right? So this one actually gets another name sometimes. It's called the fissure of Rolando, right? So if I'm a standardized test, I'm not going to call this the central sulcus. I'm going to call it by the name that's less heard of, right? So that's why I put some of these things in there. It's just so you've seen them before. So if it ever pops up again, you're not completely lost. But if this is called the central sulcus, and that's what gives us the term precentral and postcentral gyrus, the lump in front of the central sulcus and the lump behind the central sulcus, also be aware that this happens to also be called the fissure of Rolando, because that's how a standardized test is going to write that. So if they say there's a lesion on the brain in front of the fissure of Rolando, what do you expect to see in the patient? Now you can answer it. Now you could say, I'm going to have some type of spastic paralysis. I'm going to lose the ability to control skeletal muscles. Something's going to be in an answer somewhere that says I've lost voluntary control of the body in some way, shape, form, or fashion. I've lost the ability to control skeletal muscles. And when that happens, they're going to be probably spastic because there's a problem in the brain. So that's what all the tools are for, right? Because you never know what type of question you're going to run into. And in the real world, you're certainly not going to have a patient that's textbook ever, right? So you have to have a lot of tools so you can just figure out what's going on rather than have something spelled out for you, right? So if there's a lesion in front of the fissure of Rolando, I'm going to look for some type of spastic paralysis or loss of voluntary control of skeletal muscles, right? That's the basics. What if there's a lesion on Broca's area, right? Then I'm going to expect that patient to be aphasic, right? Oh, came back to me. But, you know, gosh, people, I'm sorry. As I was describing those things, I had my screen in front of me and you couldn't see it. So again, here is the central sulcus. Here is the lateral sulcus. Sometimes we end up calling this one, right, the fissure of Rolando, right? And sometimes this is called the fissure of Sylvius, right? Theirs is a little bit different. They say Sylvian sulcus, but it's Sylvius, I think, was the guy's last name. Rolando was this guy's last name. Broca, I think he was an anatomist or a neurologist. So these are named after people. Right? But again, if I have a problem that's sitting in front of the fissure of Rolando, where is that? Well, the fissure of Rolando was just another name for the central sulcus. So when I was describing that, I mean, all you could see, because I forgot to share with you, was just blank paper and probably me getting excited with my mouse or something like that. But I was pointing at this. I was pointing at this. So feel free at any time, if you can't see what I'm talking about, just say share screen or something like that. Just type it in chat. But here again, this is a deep fissure in between, say, the frontal lobe, parietal lobe, and temporal lobe. So I was mentioning that. And here's that deep fissure that ends up being between the frontal lobe and the parietal lobe. So again, we sometimes call this the central sulcus because the sulcus is a depression. And this is called the pre and postcentral gyrus because that's the lump in front and behind the central sulcus. But on a standardized test, they're probably going to call it the fissure of Rolando rather than central sulcus because this is too easy, right? So if they say I have a lesion on the lump in front of the fissure of Rolando, what would we expect to see in the patient? They're seeing, do you know what the precentral gyrus is responsible for? And what would happen if we had a brain lesion, maybe, which would be a type of upper motor neuron lesion if it happens to be right here, right? So that's just ways that we could word the question and ways that you can answer it based off what you know. And then when I was talking about Broca's area, I was kind of circling around this little area right here. And I was saying, what if we had a lesion right there? Then maybe I wouldn't be able to talk, or the patient wouldn't be able to talk, right? But that led me back to what I was going to mention to you before, which when we use the word stroke, the word stroke usually indicates that we have some type of permanent change. Versus if I have the word ischemic, that usually means temporary, right? So if somebody's got some type of ischemia and it hasn't gone into full-on stroke or infarction, it usually means it's temporary, right? So stroke obviously is the same thing as saying some type of neurological infarction. So the time that we mentioned these words before was probably first back in cardio in anatomy 2. And I put the 2 words on the board. I put the words ischemia on the board, and I put the word infarct on the board, and they share the same definition. Ischemia is too little blood to meet metabolic demand, too little blood to meet metabolic demand. Infarction is the same thing. It's too little blood to meet metabolic demand, but it's prolonged. It's prolonged ischemia. And so this leads to tissue death. So that's what infarct implies. And infarct is ischemia that lasted too long, and therefore the tissue died. So tissue, right? Dead. Sad. Okay, dead tissue. Looks like dead toast, but dead tissue. Okay, tissue died, right? That's an infarction. So what was cause of that? Ischemia. Too little blood got to that area. So what leads to ischemia? Maybe a blood clot, maybe a dissected aneurysm, right? Because if the blood's no longer in the tube, how is it going to get there? Or if the tube is blocked, how is it going to get there? But not all blockages or blood loss are going to create prolonged ischemia. Sometimes they'll clear up, right? Maybe on their own, or maybe after you give a patient some type of blood thinner, something like that. So that's where terms like stroke versus transient ischemic attack might come from, where a transient ischemic attack has all the same signs and symptoms of a stroke, but then they disappear after a while and everything goes back to normal. So that's the only difference between stroke and TIA. Is transient ischemic attack is basically saying it's kind of coming and going. It's not permanent, right? It's temporary attack, where stroke implies that it's permanent. It's a permanent change. So that was what I was going to before when I was sidebarred into upper versus lower motor neuron lesions. So if I end up having a stroke of the precentral gyrus, or the lump in front of the fissure of Rolando, then you can expect that hemiparetic gait is going to be permanent. Versus if I have TIA in the precentral gyrus, then they might have posturing. They might have a full-on problem with their gait, but it'll disappear. So one way we can sometimes test a patient to see if they got any of that stuff going on, like let's say we suspect there's a TIA, have them stick their hands out like this and see if one hand changes. See if one hand starts to rotate over like that. And you're saying, don't do that. And they're like, I can't help it. That's indicating that they probably got a TIA going on. So have them stick their hands out like this and see if it starts to posture on its own. That's indicating that there's something creating the upper motor neuron lesion on the brain actively at that time. So they won't be able to hold the hands voluntarily in the position you're telling them to. So tell them to stick the hands out like this, hold it like that right out in front of them, right? And you'll notice that one hand starts to flip over. Right? So that's a little trick you can use. I used to have to do all that stuff in my office because I tried to keep my practice as cheap as possible. So I didn't want to do a lot of diagnostics. I didn't want to take an x-ray unless I absolutely had to, so you can use little tricks to do everything. This just divides the cerebrum up into different parts. We've covered, believe it or not, a lot of information. We covered the entire theme of what this remainder of the PowerPoint is about. So now what I need to do is I need to go through it and help break it down for you, because there's a lot of information on here. right? Like what happens if we damage the frontal lobe? Well, everything that we talked about, like what if Broca's area is affected? Well, you're going to have some type of aphasia, right? And sometimes patients will become aphasic when they have something traumatized in the brain, or maybe sickness, or really bad electrolyte disturbance. They might end up having temporary aphasia and they can't talk to you. So you're gonna have to figure out stuff on your own. You can't ask them questions. They might have temporary aphasia, right? But that's indicating that whatever you thought was maybe localized and wasn't in the brain has spread to the brain. So that's good, right? It tells you something, right? So if they had some type of infection, maybe it's become septic. Because if they got aphasia going on, and they didn't have any head trauma or anything like that, then you're suspecting maybe a stroke, a TIA. But if they already have something else going on, it's probably related and it's bigger or more widespread than you thought. Right? But again, the basic idea is if I have an effect of Broca's area, what are you going to see? They're not going to be able to speak anymore, because that's what Broca's area is for. It's for allowing them to speak. So if I have a lesion on Broca's area, then I can't speak. So that's a form of aphasia. So we call that Broca's aphasia. If I am saying that my primary motor cortex is affected, then what are we going to lose? The ability to move, right? We won't be able to move. So that's why we have to, again, learn and memorize what everything does. So if there's a deficit in that, we know where to go back and look, or where to suspect the problem is located. This is actually a really nice picture of the brain right here. I stuck some big lines in there, just separating the frontal lobe, because there's so many colors here, from the parietal. Here's the occipital, here's temporal. So I stuck a line right there and a line right there. But again, that would be that fissure of Rolando, fissure of Sylvius and stuff. But this is all frontal lobe. That's the precentral gyrus. Here's postcentral gyrus. Right? Kind of right there, but still, you get it. Broca's area. Here's what's we sometimes call the prefrontal cortex. This is all your higher thinking. This is all that cognition and stuff. So if we have problems in these areas, what can we expect? Right? Maybe loss of movement, maybe cognitive disorders. What if there is metastasis coming from breast cancer? Usually with breast cancer, it's going to go to your armpits, and believe it or not, it goes to your brain. Right? So when you have metastasis from breast cancer, probably going to have some cognitive disorders going on, right? So changes in neurology. Okay? So big lump in the breast and cognitive problems, that's a problem. It's a big deal. Right? So again, we learn what the parts do, and then if they're not functioning, why? Why are they not functioning? So, but still, these would be indicators. Like if somebody's got dementia, or if somebody's got delirium, we know something's happening to the frontal lobe at least. Right? So I'll go back and I'll go over some of these things, and we're going to start picking apart some of these slides, because I know there's only so many months in summer for you to learn all this stuff. So I'll go back and pick out some very important stuff and describe some of these terms to you. But let's take a break first. We'll come back to this slide in just a jiffy. But let me go ahead and pause the recording. And we shall pick up where we left off. So prior to the break, a minute ago, we were kind of going over the big idea of looking at the CNS. And as we go through it on the many slides that we have upcoming, we're learning about some basic functions of the different parts of the CNS. But the overall kind of overarching goal is, once you determine what the different parts of the CNS are responsible for, and we end up seeing deficits in those areas, then we're better capable or able to localize lesions. And again, lesions can be many different types, which we've already seen different forms of. You could have a blood clot because of some type of tear. You could have inflammation from some type of infection. You could have localized swelling because of an aneurysm. So that's why we use the word lesion, because it's basically just all inclusive and all encompassing. And sometimes when we're localizing lesions, we're not going to get it right on the epicenter. We might just be in the general area, which is fine. It might be the entire frontal lobe has been affected. And so I might end up getting some type of motor deficits. I might get cognitive disorders. I might lose the ability to speak. But again, if it's limited to just those things, and I can feel pinprick to the skin, and I can still see, we know part of the brain has been spared and part of the brain is affected, and it's just toward the front part of the brain, which means it's not near the brainstem and the hypothalamus, which is great. It's not good for the patient, but it's better than it could be, but if we start noticing all those deficits happen to be in pH, in blood, oxygen and carbon dioxide saturation, and breathing rate and heart rate and stuff like that, that's a much bigger problem. So if the patient's temperature is all off, their chemicals are all messed up, their electrolyte balance is all jacked up, the heart and the breathing's all messed up, now you've localized the lesion at least to the hypothalamus, pons, and medulla. So maybe more of a central brain issue. That's a way bigger deal, way bigger issue. So clearly that would require much more emergent care. You're going to have to get that pressure off fast. But again, picking up where we left off, we were looking at the cerebral hemispheres, and part of the frontal lobe is for, higher brain function. So thinking, cognition. So when this area does get affected, either by chronic diseases or acute manifestations, then we can expect to see certain cognitive disorders. So I think one of the most common cognitive disorders that people usually hear about would be Alzheimer's, and for good reason. As we age, certain changes in the brain occur, and with Alzheimer's disease, they have limited it down to the buildup of what's called amyloid plaques and neurofibrillary tangles caused by tau proteins. So that's nice because it's kind of telling us, what's present in a person that has Alzheimer's, but it doesn't necessarily give cause. So they're definitely finding indications of this person, hey, they have Alzheimer's disease, and we notice this stuff is present. So, definitely be familiar with those words. Why am I telling you? It's a good, easy test question, standardized test question. So if they talk about the presence of amyloid plaques and neurofibrillary tangles, they're talking about Alzheimer's, because that's the things they've noticed happens to be present in patient in conjunction with them having Alzheimer's disease. And the reason we've heard of this one before so often is because it is the most common form of dementia. Okay? So typically with dementia, because it's age related, it's going to be a chronic disease, slow onset. Usually the difficulties with memory. This, I think at one time was supposed to say spatial recognition. It has somehow changed into special recognition. So let's go ahead and change that back. Confusion, agitation. And a lot of times the agitation is coming because of these things, right? It's coming because they're confused. It's coming because they don't recognize their surroundings. It's coming because they can't remember things when they want to. And so it's basically you're dealing with the fact that you're getting old and your brain's not functioning the way it's supposed to. So pretty good reason to get agitated. One type of dementia-like, let's say, symptom that we sometimes see in patients, though, that's quite different because of the onset, which is going to be very rapid, is something called delirium. So delirium ends up being very similar to dementia. But this is, again, slow onset, usually associated with aging or chronic disease. This is something that comes really abruptly. And if it comes really abruptly at a certain time of day every day, maybe we might call it something different, like sundowner's syndrome. But delirium can happen in a patient for many different reasons. It again could come from trauma. Maybe there's a massive contusion on the skull. Maybe they have some type of severe electrolyte imbalance going on, right? So it could be because of some type of acute kidney failure that they experience delirium. But if they're becoming very all of a sudden confused, they can't remember anything, they don't know where they are, maybe that's what they're saying. They're saying, where am I? Right? That is inability to deal with spatial recognition. Like, where am I? I'm lost. I don't know where I'm at. But that's delirium. So again, the big difference between dementia and delirium is the onset. How quickly did it come about? But again, a lot of confusion, maybe some type of, similar to sundowners, this sudden urge to do things that you normally wouldn't do, like just get up and walk somewhere. without any idea about where you're going. And that's something that we definitely see in sundowners, maybe not necessarily in delirium. Delirium, they might be bedridden. Again, maybe they have some type of other condition going on. Maybe the kidneys are infected. Maybe they have some type of heart issue that's messing up kidney perfusion rates, and that's causing electrolyte imbalance. Maybe there's something going on with the hypothalamus. But again, this is going to be a rapid onset. And if it happens to come at a certain part of day, usually as the day starts to get long, maybe 5, 6, 7 o'clock at night, then we usually change the name to sundowners syndrome, which is a rapid onset of delirium, usually occurs at nighttime as the sun starts to go down. Right? I've seen this personally before. It's a very scary situation. It usually requires 24/7 care in that person. Like if they're experiencing delirium because of radiation therapy, like whole brain radiation, or if they're experiencing sundowner syndrome, once it kicks in, you can't leave their side. You're going to have to watch them the whole time, or have somebody watch them the whole time, because there's this constant urge to get up and move. And a lot of times they don't know where they are, where they're going. They're probably not heading anywhere in particular, unless it's something that was just so habitual that they feel the need to do it, right? Like maybe they'll start making breakfast at 8 o'clock at night just because they're so used to making breakfast, or maybe they'll start fixing a bed, at 8 o'clock at night, and then they get in it, and then they'll get up and they'll fix the bed again, and then they'll get in it. So they might start doing something habitual, but you can tell they're just not ever present. They're not with you anymore. So there is definitely that sign of delirium, memory loss. They don't know what they're doing. They don't know why they're doing it. But if it starts to come at a very certain time of day, usually as the sun goes down at night, that's a good indicator that they have what's called sundowners syndrome. Right? Very scary thing to see in a patient. Parietal lobe, again, when you get into the parietal lobe, we're dealing with some type of somatic sensory input. So again, the postcentral gyrus is one of the key places in the parietal lobe. We sometimes call that areas 3, 1, 2. And then you also have areas 5 and 7, which we sometimes call the sensory association area, or here it's called the somatosensory association area. So again, by basic book definition, this part right here, the postcentral gyrus, would basically be where we find the sensory homunculus. And again, this is a visual representation of parts of the brain that are responsible for these different parts of the body. So more areas of the brain are going to be responsible for hands than, say, the kneecaps and stuff like that. And when you think about it, it makes sense, because I use my hands a lot to decipher the world around me. So if you ever sometimes walk around with your eyes closed, or you're walking around at night and you don't want to turn lights on, we sometimes walk with our hands out, and we'll feel the walls around us, and we'll kind of feel for the switch, and we can feel things and tell what they are without having to look at them. So it makes sense that we have a large area of the brain dedicated toward sensation coming from the hands. And it also makes sense that we have a large area of the brain dedicated to controlling the hands, because they manipulate objects around us. But again, in the parietal lobe, this is the sensory part of the brain. In the very first area of the parietal lobe, that postcentral gyrus, that is where we're picking up most of our information from skin and joints, right? So again, somatosensory stuff. So this is called the primary somatosensory area. This is called the somatosensory association area. So this tells us what we feel and where we feel it. This gives us information about it, right? So again, when I was taught neuro, we were taught a little bit different about somatosensory association area. And I don't think there's a definitive answer of what it actually does, but by book, this tells you what you feel. This tells you maybe what it came from. Like if I have felt that before, then I can give, I guess, context to whatever I'm feeling. So let me show you, for example. I'm going to put a couple of objects on my paper right here. I'm going to do something like that. And I'm going to close my eyes, and I'm going to reach out, and I'm going to feel these things. And the first thing I'm going to do is just tell you what I feel. Okay. So when I reach out, I can feel and I already knew this, so it's kind of cheating, but I can feel 3 distinct objects, right? One object feels long, thin, cylindrical. This part feels like rubber. This part feels like plastic. Can't really tell what this is, but I can tell it moves a little bit. You know, I push it and it clicked. So my post-central gyrus is what's giving me all that information. It's giving me the touch. It's giving me the proprioception, like how thin is the object? How much did my fingers have to move? Like proprioception's muscle stretch, tendon tension, and joint angle or joint position awareness. So it's telling me how much is the hand closed, right? So that's what's giving me a lot of information about this object. And when we have something called stereognosis, which normal people do, that means I can determine what an object is by touch alone. So the part of your brain that's feeling that and giving you the information is right here. And then the part of the brain that determines what it is you're touching is right here. So that's what they mean by association area. I'm going to associate it with a memory, or when I felt this before, what it was. So that's one explanation for that area. So if again, my eyes are closed. If I do this, this object's much smaller, right? Round, I feel a hole in the middle, right? And this is just one of my little silicone rings. So I knew what that was. It's pretty easy to determine. And this is something in between, right? It's weird shape, but I do feel like a little thing on the end of it right there. So I know it's got to be some type of key. I mean, and I'm just doing that because, I mean, again, I knew what this was before I put it down, but maybe that gives me an indicator that it's a key ring or something like that, because I can feel this little thing on the end of it. But again, this is a weird object. If you had just handed me this and it didn't have that thing on there, I would have no idea what it was. But I'd probably start hitting buttons and it would probably start making a noise down in the garage. So that's not good. But yeah, that one I never would have gotten if I hadn't looked at it. But that was pretty easy to determine. That was pretty easy to determine. So my somatosensory association area had memories of things like these before, right? So, but again, when I was in neuro, we learned that as something else. When I was in neuro, things that were represented well by your post-central gyrus would have been things like light touch, fine touch, two-point discrimination touch, things that we can pinpoint and narrow down to a very small part of the body, while the somatosensory association area picked up touch that were more scattered, like itches and burns, where we have a hard time firmly localizing it. You know what I mean? Like if I have an itch, you know, sometimes I know the area in general that itches, so I might scratch it overall, but I can't tell exactly where it is until I really hone in on it. And then I'm like, oh yeah, there it is. That's the spot. So why we couldn't localize it very well is because it wasn't represented directly on that post-central gyrus. Like itch and burn doesn't have the localization on the post-central gyrus like fine touch would, right? So it gets spread back to this area, maybe carried in by the lateral spinothalamic tract, and it's more general in nature. So that's what I learned this area of the brain was for. But again, we're picking up some type of sensory information. It's stuff that we're consciously aware of. So if for any reason whatsoever, I can't feel and determine what objects are, maybe it's this part of the brain, maybe. Okay. Again, we don't know. Could be a tract. You know, if I'm only missing pain and temperature, then maybe it's a tract like lateral spinothalamic tract, right? So if I can still pick up touch and pressure and proprioception, we know it can't be the entire parietal lobe, right? Because I can still feel those things, but if only pain and temperature is missing, right? Even though that maybe might tend to go more in this area, that's probably more tract related, because it's basically saying dorsal columns is intact, anterior spinothalamic tract's intact, but I'm only missing information coming from lateral spinothalamic tract. So let's look in the cord maybe. So again, we're getting information. We're not necessarily getting the entire picture all the time, but we can at least narrow down where a lesion might be located. So if I'm missing all, you know, somatosensory sensation, then yes, I would certainly think parietal lobe. But, you know, again, it's just a piece of information. Let's see. Let me go through some of these things. Temporal lobe, maybe if we end up with problems with balance, maybe problems with auditory sense, we could certainly think of the temporal lobe. And one interesting thing about temporal lobe is recognition of familiar faces actually occurs here. Isn't that wild? Processing of written and verbal communication, not such a leap right there, because we do have what's called Wernicke's area that's kind of sitting in this region. So Wernicke's area is a little bit wider than just that little spot that it's representing here. It actually kind of goes in between your parietal, temporal, and occipital lobes, believe it or not, because we can visually see certain things that's definitely like written language or maybe sign language. So this ends up being a mixture of multiple lobes where we're able to understand spoken or written language, right? It's like your sensory area for speech and language, while Broca's area is your motor area for speech and language. But if a person has Wernicke's aphasia, they're going to have a difficult time understanding you, and they're going to have a difficult time making any sense with their words. So they might talk, but they're probably going to have a lot of what's called confabulation. They're just going to talk a bunch of nonsense, right? So they're going to say words, but the words don't have any order. They don't have any syntax. They don't seem to represent anything. They might say, Coach Sofa Bear, you know, and you're just like, what? But that's an example of Wernicke's aphasia. So again, they're confused when you're talking to them. When they try to talk to you, they're probably very agitated and they're not making any sense. But it could indicate that we got something going on over here. But let's say they can talk and understand, but they are looking at their family members and they don't know who they are. They're like, who are you? You're a stranger. So obviously, if they're looking at the doctor and they've never met the doctor before, or the nurse, or anybody in that room, that's okay because they've never met them before. But let's say the family comes and visits and the person's looking all confused and you're like, what's wrong? And they're like, I don't know who these people are. Maybe that could point toward the temporal lobe when other things might not. So again, that's pretty interesting. Right? So here's Wernicke's area. So again, Wernicke's aphasia. Always a good test question right there. Wernicke's gets asked about a lot. Anything that's got people's names in it, you can expect gets asked. So that's why I made sure to tell you about the fissure of Rolando, right? All that kind of stuff. Broca's area, Wernicke's area, these are named after people. Those tend to be very popular standardized test questions. Occipital lobe, I don't want to get too deep into this because I don't need us necessarily diagnosing the different types of hemianopsia, but I do want you to be familiar with the concept because we'll talk about it again in neurosensory. The term hemianopsia, I think this is the old way of spelling it. They've shortened it over the years. I think they sometimes call it hemiopsia now. Again, it's kind of like a glass half full, glass half empty. This means you have like half vision. This means you've lost half vision, like hemi, like half. Anopsia, put an A or an AN in front of a word, it negates it. Opsia, to see. So I half can't see. Here it says I can half see. Right? So it means the same, but it's a type of blindness. It's a type of blindness. And it's different from total blindness, which would essentially, like if these are the eyes looking at you, like if I'm blind in the right eye, so if it's looking at you, right, left, I'm totally blind in the right eye. Maybe that was due to detachment of the optic nerve, something like that, right? Or if I'm blind in both eyes, right? Maybe it was congenital. Maybe that's how they were born. Maybe they developed it over time. Maybe they had a huge tumor in the occipital lobe. Maybe they had a giant stroke or something like that. And they became blind after that. Again, it would kind of give us localization probably. If both eyes are completely blind, then that occipital lobe must have been completely obliterated, right? But sometimes people end up getting a type of partial blindness called hemianopsia, where it's just maybe the lateral eye field that's lost, right? And maybe it's the lateral eye field on that side, the medial eye field on this side. Maybe it's two medials, right? And sometimes you can actually localize a lesion based off the type of hemianopsia. So real quick, we're looking at the eyes from a different perspective now. Let's pretend we're looking down at the top of a head. And here's a nose, like we're looking down at the top of the head. Here's an eye. Here's an eye. So let's say that's the right eye, that's the left eye. Each eye has two eye fields. You have a lateral and a medial eye field. So obviously toward the nose is the medial eye field. Before we get the information back to the occipital lobe, so again, let's say this is an occipital lobe on one side, here's the occipital lobe on the other, right? Everything in the brain's lobular or bilateral. The only thing in the brain that's not dualed or lobed is the pineal gland, right? Pineal gland is the only singular object in the entire brain. So you have two thalamuses, thalami, whatever you want to call it. You kind of have two hypothalamuses, if you will. You have a right and left to everything. We just don't say it. It's just assumed knowledge. So we have two occipital lobes, right? And essentially what this lobe is going to receive is information coming from both eyes. Same thing with this lobe. But before we get that information back to the occipital lobes, information has to go to the optic chiasma first, which happens to be right around your pituitary, right? So with your optic chiasma, which is going to look something like this, lateral information from each eye stays what's called ipsilateral. It's going to stay on the same side. But medial information will always cross over. Right? So if I were to get a tumor of the pituitary gland, which we call a pituitary adenoma, that's going to sometimes give me a certain type of hemianopsia. So let's say the tumor ends up presenting right here, okay? What would be lost? Well, some of the information heading over to this side is going to be lost, so I'm not going to be able to see that. And some of this information maybe heading along this side is going to be lost, so I'm not going to be able to see that. So it'll kind of give you a certain type of hemianopsia. But when I end up looking at the occipital lobe and I'm saying, well, where's the information coming from? So for example, this is where it gets hard because now I'm going to flip the picture and it's going to be facing toward us now. So this was, let's say, top of the head. So this is right, this is left. Now it's flipped around. Here's right, here's left. What didn't make it here if I have a tumor there? So the information got sent, let's say the optic nerve's good. Let's say the optic chiasma is good. But what didn't make it here? Well, the medial field of the right eye didn't make it here. So that's right there. And then the lateral field of the left eye didn't make it there because there's nowhere to go anymore. This is messed up or destroyed. So the lateral field of the left eye would be messed up. So you'd have a hemianopsia like that. Isn't that wild? But let's say I had a tumor right here, right where the pituitary's at, that would look different. Isn't that crazy? So sometimes if a patient presents with a very unique type of symptom, like hemianopsia, it's going to point toward one of two places. It's either going to point to the optic chiasma, or it's going to be pointing to the occipital lobe. And based off the type of hemianopsia that they have, it can tell you exactly where the tumor's at. But it can eliminate the optic nerve, right? Because if the optic nerve was damaged, then I'm just going to basically lose all vision in that entire left eye. Or if this optic nerve was damaged, I'm losing all the vision in the entire right eye. But if it happened here or here, then you get partial blindness or hemi blindness. Isn't that cool? So you can actually determine where the tumor would be. And a lot of times it's in the optic chiasma because of things called pituitary adenomas. So if your pituitary is your master gland and you got a patient presenting with hemianopsia and a bunch of hormonal issues, you know where the problem's at, right? So again, it's a unique symptom, so it's going to point to unique places. So that's nice. It's nice when you have symptoms that are just kind of off the wall or unusual. But again, I'm a consult, right? Just do that. But you know that they have a hemianopsia by doing some of your certain eye tests. So eye test for that one, we might just do like a cardinal fields of gaze test, or we might do there's a what it's called an eye field test. And a lot of times, like if I am the person doing the testing, I might stand behind the patient. This might be me. And the patient's going to be facing away from me. So again, there's the nose. I'm just showing you how the patient's facing. So here's an eyeball and here's an eyeball. And I might take a hand right here and I might wiggle my fingers and I might say, tell me when you can see this. And I'll be coming around like this, right? So I'll be like, tell me when you can see it. And if they can see it right here, that's good because that means their lateral eye field's intact. But if they have to wait for me to get all the way up here before they see it, that's problems. That might say that this is missing, right? So if they can't see it and I'm like, just let me know when you see it. And I keep going, I'm like, hey, just let me know when you see it. And they're just like, okay. And they're like, okay, I see it now. They might have lost, that lateral eye field. So that can kind of tell you whether they have hemianopsy. And of course, you can do more specific tests than that, but that gives you an idea that something's messed up. Parkinson's disease and Huntington's disease, be very familiar with these things. Yeah, it is exactly what I did. Yep. That's the exact test I was doing with you. With Parkinson's disease and Huntington's chorea, both of these are basal ganglia or basal nuclei disorders. Usually the key components when you're diagnosing Parkinson's or Huntington's disease is you'll notice that the patient has what's called resting tremors, okay? So resting tremors are essentially the patient shakes or moves or twitches when they're not trying to do anything. That's different from, like, say, an intention tremor. Like an intention tremor usually points toward a cerebellar issue. Usually that's cerebellar, and it's probably MS that's causing an intention tremor. But let's say I'm reaching for that pencil right there and my hand shakes, that's an intention tremor. Or if I say, touch your nose and then touch my finger. If I tell the patient, touch your nose, now touch my finger, they can probably do that. But if I move the finger and I say, all right, touch your nose again and touch my finger, and I've moved the finger, they might do like that. Or if I move it away, they might do like this. That's an intention tremor. So that's why we sometimes test for what's called dysmetria. Like I'm kind of seeing coordination too. I'm like, can you touch my finger, first of all? And how good are you at it? Like I'll say, touch my finger, like touch your nose, touch my finger. All right, touch your nose, touch my finger, touch your nose, touch my finger, and I'll move it, but I'll also move it toward and away. If we notice that there's an intention tremor while they're trying to do that, could indicate that we have some type of demyelinating disease or cerebellar tumor. So MS would probably be the first thing I would think of. But again, that's an intention tremor. So that's not what we're seeing in Parkinson's and Huntington's chorea. With Parkinson's and Huntington's chorea, their tremors are when they're just still, when they're relaxed, when they're sitting, or they could just be standing, but they'll shake, right? Or they'll writhe, right? So if it's Parkinson's, the resting tremor tends to be very repetitive, right? It repeats over and over and over again. And usually there's a number of what we call cycles per second, or there's a Hertz frequency to it. And the most common Parkinson's resting tremor is this one, right? Where the hand will sometimes be clasped together or maybe loosely, but it just shakes like that. Just shakes like that. That's the first sign of Parkinson's usually. And I believe it or not, I've had a patient before and they didn't have the complete what's called pill rolling tremor. They just did that all the time. But they did it in a weird way that I was like, do you know that you're doing that? You know, because that's not why they were there. They weren't there because they had some indication that they had Parkinson's disease. I don't remember what they had. They had like a swollen ankle or something like that. I'm like, dude, just put some ice on it, you know? But they kept doing that while they were sitting and I was writing notes. And I was like, are you noticing that you're doing that? And they're like, no. And I was like, we might want to get something scanned on you. We might want to do some tests. And he had Parkinson's, you know? But that's all they were doing. They were just doing this thing over and over and over again. But it eventually would have turned into this, right? And that's called a pill rolling tremor. And it eventually would have moved further up the body. So with Parkinson's, some of the signs and symptoms that we end up seeing with that is the patient starts to get what's called bradykinesia, which is very slow movements. So again, that pill rolling tremor I just showed you is at rest. or they're not using that hand. So they might be standing up and the pill rolling tremor might be occurring in the hand that's just kind of sitting by the side, and it's just doing that same repetitive motion, right? So again, the hand itself wasn't trying to do anything. It was just resting, and that's when the pill rolling tremor occurs. But when they do try to move it, if they can, it's very slow and rigid. So we call that bradykinesia. So we can see that in the gait as well. So notice this person's having a real difficult time getting started, right? Everything's real rigid. They're very slow. Here, he's kind of doing the pill rolling tremor while he's walking. You don't always see that. Sometimes their arms are just very stiff. So when they do start moving, you'll notice that the face stares. It's just a complete stare. We call it mask-like faces is what that's called. But you start to see this cogwheel festinating gait. And so they have that difficulty time getting started. But this is an example of, again, upper motor neuron lesions. The body's real stiff. But in this case, it's because of lack of dopamine, right? So everything has become very slow and rigid, right? So that's what the bradykinesia is. That's the gait that we just saw. That's a festinating or Parkinsonian gait. Sometimes they call it cogwheel rigidity. I don't know what a cogwheel is. I know it has something to do with gears and stuff like that, but I don't know. Maybe it looks like it needs oiled or something. They do become increasingly rigid over time. A lot of times that patient will get curled up and they'll basically be wheelchair ridden after a while. And so sometimes if they want to lay down at night, it takes some effort to get them to get out of that kyphosis. You know, it's going to take some effort to get them to actually be able to stretch out supine if they possibly can. But eventually they're going to start getting difficulty swallowing. Ultimately, they're going to lose the ability to breathe. And that's what's eventually going to kill them. So with Parkinson's, of course, there's no cure just yet outside of stem cell therapy. But a lot of the medications are meant to replenish that loss of dopamine that we're seeing. And dopamine is just one of those ingredients that the basal ganglia need to modulate movement appropriately. And one thing that the basal ganglia does is it makes the motions, what's the word I'm looking for? Baby bear-like. Like you don't want motions to be so extreme, you know, where it's just like hemiballismus. And you don't want motions to be so little that they're not accomplishing anything. We need something in the middle, right? That's modulation. So we use a mixture of neurotransmitters like acetylcholine to excite movement, and then dopamine to kind of tampen it down a little bit. And without that dopamine to tampen it down, everything gets too excited, and that makes the muscles too rigid. And so they're actually slow because they're too tight, right? And you'll see that as it progresses, because the patient will eventually become so stiff you can't even move them anymore. But when that starts to affect breathing muscles and swallowing muscles, obviously you can't function any longer. So that's Parkinson's disease. But again, you see that pill rolling tremor, that's early on. You start to see that stare and that very rigid walk. That's a little bit later. So they've probably already been diagnosed at that point. But the treatment is to replace what's missing. So the cause in this case of this disease is they are no longer producing dopamine. So you could possibly treat it with levodopa, and that should start to relieve some of the symptoms, or anything that could stimulate the presence of more dopamine. So now we're finally starting to get into something where here we have an issue, here we know exactly what's missing. So let's go ahead and bring it back into the body artificially and see if that fixes it, right? And sometimes that's how you diagnose too. Sometimes you diagnose by treating, and if the treatment works, then you've got a decent diagnosis. With Huntington's disease, the similarity with Parkinson's is you have some type of motor dysfunction. It is basal ganglia related, and you have resting tremors. So that's why the two always get taught together, right? So again, basal ganglia are deep parts of the brain, deep nuclei of the brain in this area, right? You can actually see the gray matter here. This is also gray matter. They're just trying to highlight these. And what they do is they make movements more purposeful and they modulate them, right? So if I end up getting damage to basal ganglia, I start getting a bunch of purposeless movements like resting tremors, and the movement itself is not properly modulated. So with Parkinson's, again, we got real stiff, and the resting tremors were like the pill rolling tremor of the hand, or you might see it in the neck, you might see it in the upper extremity. It can be anywhere, but it's repetitive. It's just when they're sitting still, they shake, right? And it's just a repetitive thing over and over and over. With Huntington's disease, you still have resting tremors, but they are going to be, so here's another screen. Sorry, I was pointing basal ganglia at, and I forgot to share screen with you again. I promise I'll get good at this by the time we get to the end of the semester. But here we can see some of the basal ganglia, which are areas of gray matter or collections of cell bodies within the brain, like the neocortex we can see out here. Those are cell bodies. All this stuff are axons. That's the difference between white matter and gray matter, right? Cell bodies make up the gray matter, and they're non-myelinated, so they appear darker. Axons are myelinated, so it has that fatty sheath, and that's what makes it appear lighter in color. But it's not just the neocortex that's gray matter in the brain. We also have deep nuclei in the brain, and the word nucleus usually means collections of, cell bodies in the CNS, but you could also call them ganglia if you wanted to. Ganglia usually refers to collections of cell bodies in the PNS, right? But again, it's a loose rule. You don't have to abide by it. So basal nuclei or basal ganglia is one and the same. Parkinson's is a classical basal ganglia disorder. So is Huntington's. Again, Parkinson's, you're going to have resting tremors that are repetitive. With Huntington's, they are what's called writhing type motions. So as we look at these patients, notice how there's more of a flailing, a wave-like motion, and it's kind of like spreading from one part of the body to the other. It's almost like an audience doing a wave in a crowd, like in a stadium. It's just going from one place to another. So it might start in the hands, and rather than it just being this repetitive motion, it's definitely a tremor because it's moving, and I'm not intending to move it. It's just happening on its own, but it's got a writhing, almost flowing type of motion to it. That's how we distinguish Parkinson's from Huntington's chorea, right? So here you can see it really advanced in this patient here. Give it a second, maybe. There we go. And here's somebody walking with Huntington's chorea. So, most of the time, these people are going to be medicated. And somebody with Parkinson's might look like they have chorea because of the medication, right? So you might get a movement disorder that ends up looking like another movement disorder because of the treatment that they're receiving. Yep. And the problem with both of these diseases, specifically Parkinson's, because you end up seeing that one a lot more, is medication is really the only treatment that we have. It's not curative. It's just slowing down the progression, and basically treating the symptoms. It's ungodly expensive. So we're talking about $10,000, $15,000 a month for medications. So it's usually impossible for a person to get it. So they have to apply for all these different types of loans or help with the government or the pharmaceutical company. So sometimes you might have a patient with Parkinson's, but when they're being treated with the levodopa, they end up looking like they have chorea. So they end up writhing a lot. But again, this is what it would look like untreated. But again, basal ganglia disorders. Let's see. Thalamus, epithalamus, hypothalamus, just knowing what they are. Thalamus, of course, is the sensory relay center. So anytime you see the word relay, associate that with the thalamus. So whether it's, eyes, like vision coming in, the word relay basically means as the sensory information is coming in, I'm going to tell you where to get processed. That's what it means by sensory relay center. If I got touch coming up the cord along dorsal columns, then I am going to direct you to the postcentral gyrus. So the thalamus is usually what's receiving sensory information, and it's going to direct it to the appropriate portion of the brain. So that's what it means by sensory relay center. So the word relay usually gives away that they're talking about a thalamus. But if I'm a standardized test, this is the question I would ask. Like in my normal class, I would say, as touch pressure and proprioception go up dorsal columns, its terminal neuron, which relays information to the postcentral gyrus, would be found where? And what gave the question away was I used the word relay in there, okay? So that's how a normal question about thalamus is usually framed. But on a standardized test, they're going to say vision, smell, sensation of the skin all pass through this structure except olfaction. What structure am I talking about? Again, they're talking about a thalamus, but they will bring up that the only thing that is not relayed through the thalamus is olfaction sense, right? So that's why we have to throw that in there. Even though it's not responsible for olfaction sense, which clearly it doesn't have to pass through there. So olfaction sense basically goes directly from cranial nerve 1, which are the olfactory nerves or the olfactory bulbs, directly to the olfactory cortex in your limbic system. It doesn't have to pass through the thalamus. We put that on there because it's an easy standardized test question, right? So all senses pass through the thalamus except for which one? Olfaction. That's how you would frame that question. It's annoying, it's aggravating, but again, the more tools you have in your tool belt, the better off you're going to be, whether it's useful in the real world or whether it's just getting past that stupid test that you have to pass to prove you can go into the real world. So thalamus, relay usually gives it away. Epithalamus, we don't use that word very much, but it just basically means I'm sitting atop of or upon the thalamus. So there is a clinically significant structure in there called the pineal gland, and the pineal gland is responsible for making melatonin, and it's part of our circadian rhythms. So a clinical feature that sometimes pops up in people that have pineal gland issues, or maybe the pineal gland's not being stimulated enough, is something called seasonal affective disorder, in which the body basically is just not getting enough ultraviolet light or sunlight. And so that ends up leading to a sense of depression. And it messes up your circadian rhythms, which are your rhythms that kind of guide normal, hormonal fluctuations throughout the day, if you will. So again, circadian just means around a day. It takes about a day for these rhythms to completely get fleshed out, right? So one of the most, studied circadian rhythms is cortisol production in the body, in which cortisol levels are usually highest about 9 a.m. in the morning, and they tend to stay fairly high, but they'll decrease down until they get to about 5 o'clock at night, and then all of a sudden they just kind of drop. And that circadian rhythm repeats itself every single day. So it's a rhythm that repeats itself in about 24-hour period. So that's what it means by circadian rhythms. And mostly it's there to help us deal with stress, because when we most stressed out, usually between 9 and 5, right? When most people are at work. So that's an example of a circadian rhythm. So pineal gland helps make melatonin, which helps you sleep at night. And it's helpful with circadian rhythms. So what the crap does that have to do with seasonal affective disorder and depression? Melatonin is also something that can be converted to serotonin, right? And there's a balance between the two. But in order for me to convert my melatonin back into serotonin, usually ultraviolet light is going to help stimulate that process. So if I don't get enough sunshine in the day, or if I'm not exposed to enough ultraviolet light, that conversion into serotonin, which gives us a sense of well-being, disappears, right? So you want to stay in bed all day, and you don't want to go outside because you've been trapped in all day and you just feel blah. So sometimes that happens with people more northern like, where it's cold all winter and you can't go outside. So you end up getting SAD, or seasonal affective disorder. So that again is something we associate with the pineal gland, and pineal gland again is the only structure of the brain that is not lobular in nature. It just looks like a little central pine cone. That's where the word pineal comes from. Just looks like a little tiny pine cone sticking out in the middle of the brain by itself, right? So it's non-lobed, it's not bilateral, it's the only singular structure. But then of course, hypothalamus, extremely important part of the body, this is where basically all homeostasis takes place. So most of our control of endocrine system comes from the hypothalamus, because the hypothalamus will tell the pituitary what to do, and then the pituitary will oftentimes tell other glands what to do. So hypothalamus in charge of mainly the endocrine system. It's also in charge of a big portion of the autonomic nervous system, and it's setting most of your set points for basic homeostatic function. So pH, body core temperature, everything, right? And so if anything compresses upon the hypothalamus or anything damages the hypothalamus, then everything's going to be messed up. Your basic homeostasis is going to be all jacked up. So everything from heart control, breathing, body core temperature, electrolyte balance, all that's going to be messed up. pH, everything. So that's a big deal. So if you start to see just general disarray from homeostasis, then hypothalamus has probably been affected. And because it's pretty close to the brainstem, if you have some type of bulge or lesion or bleed, maybe pons and medulla get affected too, right? Because these are kind of the lower areas of the brain, right? So maybe a central bleed or a midline bleed could actually push the brain over. And if it's in the lower portion of the skull cavity, then these areas can be affected. So you sometimes see all three get messed up at once, which is never good. Well, sometimes the person will just cook themselves. They'll literally just become like a piece of toast, and they'll cook themselves internally. Midbrain. I'm probably not going to be asking you about cranial nerve location, but again, the nice part about knowing that anatomically is if I saw a problem with oculomotor and trochlear nerve, we could trace that back to the midbrain. But substantia nigra, this is one of those areas that we associate with making dopamine, and it contributes to basal ganglia function. It's also affected with Parkinson's. Okay? And then corporal quadrigemina. I don't know of too many diseases that we end up seeing of corporal quadrigemina, but what makes up the four twin bodies are the superior and inferior colliculi. So those are usually the parts of the brain that get highlighted when they show something called a midbrain or maybe a mesencephalon. So if I'm talking about what structures would I find in the midbrain, or what structures do we find in the mesencephalon, that would be a fair question, I would say. Your two superior colliculi and your two inferior colliculi, which make up corpora quadrigemina, are essentially your main structures of the midbrain, right? So again, superior colliculi helps you kind of move the body to follow a moving object with the eyes. So it coordinates eye movement, neck, body movement, so you can follow an object with the eyes. And inferior colliculi helps you turn towards sound. So of course, we want both of those to work. So you could snap a finger and see if a patient will turn toward it. There you go. That's how you could test the inferior colliculus if you wanted to. And sometimes we'll be able to go further with an eye test if you wanted to, but again, that would really not tell me as much as you would think it would. But sometimes when you do the cardinal fields of gaze test and you see nystagmus and stuff like that, some examiners will actually go past that to see if the neck will move with the eyes and stuff like that. But again, it's a very old, rare test that you would ever see anymore. Pons, think breathing. So respiratory rate depth is pons, medulla, cardiac control center. Even though medulla also houses respiratory centers, I tend to think, lungs and breathing with pons, heart, vasomotor function with medulla. So that's definitely good things to know. So if I have pressure on the medulla, what could I expect? Maybe dysrhythmia in the heart, maybe hypo or hypertensive. Maybe it's fluctuating back and forth, going crazy, like he was hypotensive now, hypertensive later, hypotensive now, hypertensive later. What could explain that? It can't just be sympathetic innervation because they would just be straight hypertensive. It can't just be blood loss because they would just be straight hypotensive, but it's going back and forth, back and forth. Well, what controls blood vessel tension to begin with? the medulla. So again, if it's fluctuating blood pressure, then think medulla, rather than if it's just strictly hypertensive or strictly hypotensive. If it's hypotensive, I'm thinking fluid loss. If it's hypertensive, maybe kidney problem, maybe the renin-angiotensin-aldosterone pathway is running too much, maybe stress, some type of stressor on the body is causing the limbic system to kick in, and too much epinephrine and norepinephrine maybe, but if it's going back and forth, what could explain that, right? Maybe what controls vessel tone to begin with. And also, when you have a lot of pressure on the brain, because we have vomiting center in the brain, swallowing, gagging, we can test the patient to see if some of their cranial nerves are intact. And those cranial nerves do end on the medulla. So if they've lost the ability to swallow, gag, right, which is part of the cranial nerve testing, and they have nausea and projectile vomiting, that could indicate that we have pressure on the brain stem. So again, it's a lot of information coming from a lot of different places, and we learned it at very different times, but it's making sense how it all kind of conjoins together. And again, nobody's expecting you to be a neurologist on your first day of the job. Just, are you seeing something that's abnormal, right? Why would I explain vomiting with headache if they have no migraines? Maybe there's some type of neurological involvement. Maybe there's pressure. That's as good as you need to go sometimes, right? Because it gives me an incentive to do a scan or an X-ray, right? Because this just isn't right. It's not why the patient came in. It's not what they're presenting with, but this doesn't seem right. That's what you're looking for. You're looking for something that just seems out of place. And where do we go from there? Let's see. Cerebellum, coordination of movements. So if a patient has problems with the cerebellum, they're going to tend to look very uncoordinated. So the gait's going to be all messed up, right? They'll be falling all over the place. Sometimes they'll compensate for it. So this person is kind of showing it. See how they're veering off to one side, kind of wobbly, right? This guy, he's had cerebellar problems for so long. You saw him trip right there, but he's compensating for it by turning the toes out and walking really wide. So if you had him maybe try to put the feet in closer, you're going to see him fall over like she is. So sometimes we'll try to bring out cerebellar ataxia by making them do a heel to toe walk. We'll put like a little piece of tape on the floor, and you'll have them walk that line of tape, putting one heel in front of a toe, and then you bring the next foot forward. It's like doing a field sobriety test for alcohol. But if they have cerebellar issues, they cannot do that because they have to walk wide just to have any balance at all, because they're already so uncoordinated, right? Ataxia, that they can't even do well, even with a wider gait, which should give them a better base, right? So if we take away that base and make it even more narrow, then that's really going to bring out the ataxia. But again, you're seeing it here, and you're kind of seeing it a little bit right there. Okay? So what do I think when I see ataxia? Again, cerebellum is the first thing that comes to mind, maybe spinocerebellar tract. But then you have to go on and think, well, what's going to cause a cerebellar issue? Could it be a tumor? If so, where did it come from? Do they have, again, maybe some type of lung cancer that metastasized? Or do they have some type of autoimmune disease? Do they have a high SED rate on a lab? Maybe just showing general inflammation. Well, maybe it's an autoimmune disease. What's an autoimmune disease that affects the cerebellum? Maybe MS. So again, MS would be the first thing I would think of. That's just my go-to for cerebellar disorders. But what could possibly indicate that? Maybe they have ataxia, which we can judge many different ways. Again, we could look for dysmetria, the inability to touch that moving finger. We could test gait, but if they just look in general drunk and uncoordinated, that points toward cerebellum. So I think MS, but other things like labs that might indicate MS is inflammation. Because if it's an autoimmune disease, we tend to have more immune overreaction. And so that can cause higher inflammatory responses. So higher SED rate, erythrocyte sedimentation rate, stuff like that. And here's some other things we might see with cerebellar dysfunction. Again, dysmetria was that thing I was showing you. Difficulty judging distance. So they would have a hard time with touching their nose and then touching a finger, touching nose and then touching the finger, or you can just have them stretch the arms out to the side and then tell them to bring the hand in to touch the nose, right? That can show dysmetria, but it's better when the object's moving rather than stationary. Dysdiadochokinesia is difficulty with rapidly alternating movements, dysarthria, difficulty with speech. In Charcot's triad, I'll go over that with you with MS, even though I think we've already had it before. That's the SIN, right? SIN is the scanning speech intention tremor and nystagmus, right? That should have been earlier in the notes. But dysdiadochokinesia, let me show you that real quick. Dysdiadochokinesia usually means you have difficulty with rapidly alternating movements. So an example of a rapidly alternating movement would be going from, like, say, let's stick a supine hand on top of this hand and then pronate it, and then supine, pronate, right? And ask a patient to do that as fast as they can, right? So they should be able to go, look at that. I'm like superhero, look at that. Look how fast I'm going. But if they have cerebellar issues, they can't do it. So what they'll end up doing is they'll start off and then this hand will flip. And you're like, nope, try it again. Keep that hand flat. Have them stick the other hand on top, show them how to do it. Have them rapidly go between supination and pronation. And then when they start to do it, the other hand will flip over. Or they'll just give up, right? So something will be off in them doing that. That's dysdiadochokinesia. But there's a lot of other stuff you can see with cerebellar disorders too. So some people use certain mnemonics. I'm not going to test you on these, but it's good to have. It's good to have. Nystagmus, we see that with certain cerebellar issues like MS. That's just the eyes jiggling, right? It's an easy test to do. But slurred speech, right? Difficulty coordinating speech, muscles, movement, tongue, everything takes a lot. Limbic system, sometimes limbic system gets involved with certain things. Most of what your limbic system does is it brings in your sympathetic nervous system when there's big stressors, and those stressors might come from something emotional or even smell, like something that's very off-putting, like a smell. But basics of limbic system is it's a place where your hypothalamus, your amygdala, your hippocampus, and your olfactory cortex all kind of combine together. They're all kind of real close side by side with each other. And when something stimulates one, it oftentimes will stimulate nearby regions. So that's why certain strong smells can remind you of something, right? Because hippocampus, we store memories. Olfactory cortex is where you interpret smell. So sometimes certain smells will bring back memories, and sometimes those memories might be good memories, or sometimes those memories might be bad memories. And if it's a bad memory, you might all of a sudden get stressed out or feel anxious, right? Or feel your blood pressure go up, right? And so it kind of combines some of these things together. Sometimes it's a bad thing. Sometimes we can use it as a good thing. Like there's certain smells, right? They can help us relax, and we associate it with something nice, right? But there's certain smells or memories that are, of course, going to freak us out. And that's essentially where things like, I'm looking for, there's certain memory things that we could use for our advantage. For example, like some people use lavender. Lavender is a smell that sometimes people use to relax themselves. But you could also go in the opposite direction, and you could have certain traumatic, memories that'll come back, and it'll literally put you in almost like a state of strong anxiety, right? So again, it goes both directions here, but it's the combining of what seems to be very unrelated stimuli together, right? Like, why would a smell remind us of anything to begin with? But if we know that it does, let's use that to our advantage. Maybe avoid the certain smells that you associate with a negative person or a negative things, but maybe start smelling certain things when you're studying. That might help, right? But anywho. Reticular formation. Reticular formation, a lot of times we associate it with certain part around the brain. stem, mesencephalon again, and it's where a lot of information is coming in. Could be light information, it could be sound information, it could be touch, feel type of information, maybe coming up from the cord. And the more that reticular formation, which is basically just areas within the cord and the brain, when they get more stimulated, the brain becomes more alert or active, right? So again, if I'm studying, maybe certain smells are going to help me remember things better. So if I'm constantly smelling coffee when I'm studying, then drink coffee right before you take your test. If lavender helps me calm down and study and memorize things, then have the scent of lavender around you when you're taking your test, right? But also at the same time, when you're studying, you're going to want a certain amount of light. You're going to want a certain amount of stimulus around you. You can't have it too quiet. You can't have it too dark. We need bright light. We need some type of stimulus just to make the brain more alert or awake. So reticular formation is something that we, again, we could use to our advantage if we know what it does, but it's essentially a place where information is coming into the brain and we can pick and choose maybe what's more important, right? So that's one of the functions of the reticular activating system. But the more light and sound and touch stimulus that we get, the more alert or awake the brain is. If we're trying to go to sleep at night, we want to eliminate those things. Let's see. And then that finally leads us into cord. So we got out of the brain and we're getting into the cord. So I think this is where we're going to pick up on Thursday of this week. And again, don't worry that we didn't get this thing done. A lot of this is just pictures. But I do want to talk a little bit, and somebody remind me about this. I do want to start talking a little bit about spinal cord cross section. We'll do a little bit of the tracks again, just kind of what do these tracks carry, what can affect these tracks. So again, things like syringomyelitis, diabetes mellitus, they affect things like lateral spinothalamic tract and dorsal columns. You know, what are they supposed to carry and what would show up in a patient if they're not intact or functioning. But also, if you can remind me, if I don't do this on Thursday, to talk a little bit about peripheral nerve versus nerve root evaluation and damage, because sometimes, again, when we're looking for lesions, it could be a very small area that's affected, but if it's affecting the cord or a nerve root, it might show up one way versus if it affects it just a little bit further out. So maybe a little bit further out in the periphery. So I'll try to remind you and go over certain indicators that could tell us whether we have nerve root or peripheral nerve injury. But let me also go back here with our course modules. Today, this is our Zoom meeting for today. Here's where we're at. We're still working on that neuro PowerPoint that we started last Thursday. We're still going to pick this back up again on Thursday of this week, and we're going to jump into neurosensory. Whatever I don't finish with neurosensory, we will throw that in with autonomics and endocrine next week. And then if I don't finish everything with autonomics and endocrine, then we can also finish that next Thursday. So next Thursday, I wasn't planning on doing anything in particular, but again, if we have carryover from one class to another, we can use that to our advantage. But this is also going to be our Q&A day. So our Zoom meeting for 6:15 is going to be a day that we can ask questions from any other chapter. And of course, you're more than welcome to stay after any class to ask questions. But this is like a big day of questions. So usually the test is going to be due by the end of the weekend. If it falls on a Thursday, our Q&A session. But this is hopefully, hopefully you've been studying the entire time, but this might be a time where you've got to certain parts of your notes and you're just like, I still don't understand this, or I still don't get this. That's specifically what this Zoom meeting is going to be for. So 6:15, we'll finish up any information that we hadn't got to yet, and we'll do our Q&A session, right, for our tests. And then once we get past our first test, the class will just be kind of on autopilot from that point. You'll know exactly what we're doing every week. You'll know exactly what to expect, but some of these things are still going to be new. But that's it for us today. So in a few minutes, I will replace this Zoom meeting invite with our Zoom recording. If you missed anything from last Tuesday or Thursday, they're here and here. So just go under the Zoom recording. This will take you to it. And that should be it. But let me go ahead, stop the recording so it can go ahead and start consolidating. And I will post it in just a little bit.